Welcome back to Mastering Medical, Part 3 of our Pulmonology Rapid Review. Infection and the Pleural Space. Pneumonia questions are won by describing the image before you name the bug, and pleural fluid questions are won by running one set of criteria before you theorize about a cause. That is the whole video. Let's start with the pattern on the film. First, the three imaging patterns. A young adult has a dry cough, headache, myalgias, a low-grade fever, and bilateral interstitial infiltrates, and is still walking around. Before you reach for an organism, describe what you are looking at. Is it a dense lobe, patchy airway-centered consolidation, or diffuse interstitial change? Lobar pneumonia is dense confluent consolidation filling one lobe, classically Streptococcus pneumonia, and it gives you the full exam findings. Bronchial breath sounds over the consolidation, egophony, increased tactile fremitus, and dullness to percussion. Bronchopneumonia is patchy and airway-centered, scattered across lobules or multiple lobes, and is more typical of Staphylococcus aureus, Haemophilus, and Klebsiella. Atypical pneumonia looks completely different. The infiltrates are interstitial or patchy rather than densely consolidated. The cough is dry, and the systemic symptoms, headache and myalgias, dominate. The phrase to hold is that the chest film looks worse than the patient does, which is exactly why it is called walking pneumonia. So describe the image first: lobar dense, bronchial patchy, or interstitial atypical. The organism follows from the pattern plus the exposure. Now name the atypical organism. A hotel guest develops pneumonia with diarrhea, confusion, a low sodium, and raised transaminases. Inside the chest, these organisms look much the same. The answer is always outside the chest. Mycoplasma pneumonia is the young adult in a dormitory or a military barracks. Dry cough, patchy infiltrates, and cold agglutinins, which are immunoglobulin M antibodies that can cause a cold autoimmune hemolytic anemia. Because Mycoplasma has no cell wall, beta-lactams do not work, and that is a favorite question. Treat with a macrolide or doxycycline. It is also associated with erythema multiforme and with Stevens-Johnson syndrome. Chlamydia pneumonia is similar but milder, often with hoarseness, and usually without cold agglutinins. Legionella is the severe one, and it is a water organism. Cooling towers, air conditioning, hot tubs, hotels, and cruise ships. The signature is that it goes beyond the lungs, with diarrhea, confusion, hyponatremia, and raised liver enzymes. It needs charcoal yeast extract agar with iron and cysteine to grow, and the urine antigen test is the fast route to diagnosis. So pair the lung findings with the extrapulmonary clue, crowding and cold agglutinins, or water exposure with gut, brain, and sodium. Now the mimic that matters, because getting it wrong is dangerous. A post-operative patient develops sudden pleuritic chest pain, tachycardia, and dyspnea, and the lungs are clear. Both of these cause hypoxemia and pleuritic pain, infection or clot. Pneumonia builds over days, with fever, productive cough, focal crackles, and an infiltrate that explains how hypoxic the patient is. Pulmonary embolism is sudden, pleuritic chest pain, tachycardia, dyspnea, and a chest film that is essentially normal, which is the point. The discriminator worth carrying into the exam and the wards is hypoxemia out of proportion to the chest film. If the patient is markedly hypoxic and the film is clear, think clot. Then hunt the risk factors: recent surgery, immobility, malignancy, pregnancy, oral contraceptives, or a known thrombophilia. Two extras: a Wells score plus a D-dimer sorts low probability patients, but in a high probability patient goes straight to CT pulmonary angiography because a negative D-dimer does not clear them. And a pulmonary infarct can produce a peripheral wedge-shaped opacity, the Hampton hump, which muddies the clear lungs rule in a minority of cases. Last pair, and it has a fixed algorithm, which makes it free points. A patient with decompensated heart failure has bilateral pleural effusions with low protein and low lactate dehydrogenase. Do not theorize about the cause first. Run Light's criteria. Was this fluid squeezed out or did it leak out? Transudate is fluid pushed across a normal pleura by pressure or pulled by low oncotic pressure. The membrane is not inflamed, so protein and lactate dehydrogenase stay low. Heart failure is the most common cause worldwide. followed by cirrhosis with hepatic hydrothorax and nephrotic syndrome. An exudate means the pleura itself is involved, from infection, malignancy, pulmonary embolism, tuberculosis, pancreatitis, or an autoimmune process. Light's criteria decided, and the logic matters. The fluid is an exudate if it meets any single one of the three. Pleural protein to serum protein above 0.5. Pleural lactate dehydrogenase to serum. Lactate dehydrogenase above 0.6. Or pleural lactate dehydrogenase above 2/3 of the upper limit of normal serum. To call something a transudate, it has to fail all three. Two add-ons that earn points. A very low pleural glucose points to rheumatoid pleurisy, empyema, or malignancy. And a milky effusion is a chylothorax from thoracic duct injury or lymphoma. Let's lock it in. Describe the pattern first. Lobar is dense and confluent. Bronchopneumonia is patchy and airway-centered. Atypical is interstitial with the film looking worse than the patient. Crowding with cold agglutinins is Mycoplasma, and water exposure with diarrhea, confusion, and a low sodium is Legionella. And hypoxemia far out of proportion to a clear chest film is pulmonary embolism until proven otherwise. Light's criteria make it an exudate if any single one is met, so a transudate has to fail all three. Mycoplasma has no cell wall, which is why beta-lactams fail and you reach for a macrolide or doxycycline. And the habit for this video: describe the image before you name the organism. That is part 3. Part 4 takes on the emergencies, pneumothorax and tension physiology, acute respiratory distress syndrome, and the pulmonary hypertension groups. See you there.